Hello, and welcome to the overview video on alterations of pulmonary function. In this video, we'll be covering the first 5 pages of the class notes, the lecture notes. So the pulmonary system, we're talking about the lungs. And so we're going to do a brief overview of the anatomy. Roughly, we divide the respiratory system into upper and lower parts. The upper part includes the sinuses, the nasal cavities, the throat or the pharynx. When we have infections, we generally think of them as being upper respiratory infections. That's just a head cold, sometimes we call that. But of course, if infections go on, the microorganisms can drip down into the lower respiratory tract and kind of take hold in the trachea, the bronchi, and then as the bronchi continue splitting and become bronchioles, eventually leading to kind of the business part of the lungs where the gas exchange actually happens. Those are the alveoli, singular is alveolus. And these alveoli look like kind of clusters of grapes, and they're all surrounded by this very rich capillary bed. And all that capillary bed is there to supply blood so that we can do gas exchange. Now, how the respiratory system and lungs are related to the cardiovascular system. I know that you've gone over this with Dr. Doig, but we're going to review it again and hopefully give you a way to remind you of how to remember the left and the right sides of the heart. So the lungs receive deoxygenated blood or used blood, if you want to think of it that way. That comes from the right side of the heart. Now, I know on this figure it appears to be on the left, but it's the patient's right side. So that blood, and this is super simplified, but that blood coming out of the right side of the lungs is going to, the right side of the heart is going to go to the lungs. This is represented up here by this capillary bed. That is where oxygen will be picked up. That oxygenated blood will be returned to the left side of the heart, and that blood will get pumped out to the rest of the body. The tissues down here represent all the tissues of the body, up in the head, down in the legs, all those tissues. This is referred to as the systemic circulation. Now, how to remember. I need you to get the right side and the left side of the heart straight. And I've told people before, I learned this 100 times and I forgot it 99 times. So I'm going to give you the way that I finally was able to hold on to this information, and hopefully it'll help you as well. So the blood that exits the right side of the heart is just going out to the lungs, and it's going to be right back. And I know I wrote it here, blood exiting the right side of the heart will be right back. I'm just going to the lungs. And the way that I finally came up to remember this was when my kid was a toddler, this child would follow us everywhere. We couldn't go anywhere without this kid following us. And so we would say, I'm coming right back. I'll be right back. I'm just going to go to the bathroom and I'll be right back. And then when she got a little older, she became a little more mobile. And then she started doing the same thing. And she would say in a super cute voice, I'll be right back. I'm just going to my room. I'll be right back. And so this is how I picture the right side of the heart. Say, I'll be right back. Just going out to the lungs. And the right side of the heart is the thinner walled side of the heart. And the reason it can be thin walled is because it doesn't have to push really hard. It's just pushing the blood out to the sides, and then that blood's going to be right back. And so that's another way to remember. It's that right side. It's going to be right back. And it doesn't have to push very hard because it's just going out to here and then back. Then the blood that has left the thorax, that has gone to the head or has gone to the legs, that's the blood that came from the left side of the heart. So blood exiting the left side is the blood that has left the thorax. And what I hear in my head for this is, if you know who Elvis Presley was, and yes, he was even before my time, but there's still this thing that I hear in my head, Elvis has left the building to disperse the crowds of screaming women. So this is the blood has left the thorax, came from the left side of the heart. And that's the really muscular, thick-walled side of the heart. And it has to be really muscular because it pushes so hard to get up over this enormous pressure and to push the blood this great distance, much farther than the right side of the heart has to push. Now, why two circuits? This is the other confusing thing. Like the blood went, okay, clearly it had to go to the lungs to pick up some oxygen, but why do you have to pump it again? Well, the problem is once the blood has been through this capillary bed, it doesn't have very much force behind it. It's not pushing real hard. And so to get it to be able to travel as far as it needs to go to oxygenate the brain and oxygenate the tissues elsewhere in the body, it needs more push, it needs more oomph, the technical term. And that's the return to the pump. It needs another pump so that it can get through the next capillary bed it has to get through. So that's what the two circuits are about. So pulmonary function, what is it all about? I mean, we all know it's just, you know, we need to pick up oxygen and we need to drop off carbon dioxide, but why? So I'm going to have to remind you of some biology that you may remember. So this part we all get, you know, you need to deliver the oxygen, get it into the blood. Why we need all that oxygen is something that's happening at the cellular level. And I know that this is hard to believe, but it all comes down to what's going on in the organelles we call the mitochondria. Those are the so-called powerhouse of the cell. They're the ones that do the conversion of energy forms. I'm going to remind you there is something called an electron transport chain that's going on in the mitochondria. This is the so-called cellular respiration. That is what we need the oxygen for. And it's not like when we say cellular respiration, you know, the heart, the cells don't have little lungs, they're inflating and whatnot. Cellular respiration refers to this process of breaking down molecules of fuel so that we can convert them, convert the energy to a form that we can use in the cells. And that form of energy is ATP. And the way we do this conversion is at the end of that long electron transport chain, we have to get rid of those high energy electrons. They've lost energy along the way and they're waste, so we just need to get them out of the body. And the way we do that is by putting those electrons onto the oxygen. That's what the oxygen is for. So we give it a couple of electrons and some protons and release it as water. And that water just goes into the plasma and then eventually can get released as urine. Amazing. Okay, so that's what that oxygen is for. Where did the carbon dioxide come from? Carbon dioxide is also related to this cellular respiration. It's from the breakdown of the food, of those fuel molecules, the carbohydrates, the proteins, the lipids, or fats that we use as fuel. We break those organic molecules, organic meaning that they contain carbon. It's a combination of carbon, hydrogen, and oxygen for the most part, and the protons get taken off. But what we're left as a waste product is carbon dioxide. And that's the stuff that needs to exit the body. And I know, again, I know it's hard to believe, but the carbon dioxide that we are breathing out right now, that carbon earlier in the day was part of molecules that we consumed. I don't know what you had for breakfast, but you know, I had some eggs, may have had some Cheerios, whatever it is, that fuel, that's where the carbon dioxide is coming from. So that carbon dioxide gets released from breaking down these fuel molecules in our tissues, that gets picked up in the blood and transported to the lungs, and that's the carbon dioxide that gets breathed out to be released as waste. Fantastic. So when we talk about pulmonary function, there are really just three factors that we need to keep track of. There's ventilation, which is getting air in and out of the alveoli. There's perfusion, that's getting blood through the capillaries from the heart to the lungs. And the third factor is gas exchange. And clearly that's the two gases that we were talking about. We have to move oxygen from the air that we just breathed in and dissolve that into the blood, and the carbon dioxide, that waste product from cellular respiration, we need to get that out from the blood back into the air so we can breathe it out. If we have problems with any of these three factors or more than one of these factors, that can lead to insufficient oxygen in the blood. That's known as hypoxemia. The big problem with hypoxemia, of course, is if we don't have oxygen, that means we don't have anybody to accept the electrons at the end of the electron transport chain. And the electron transport chain fills with electrons and you can't get rid of them. So the whole thing kind of grinds to a halt. So you can't make a bunch of ATP. If you can't make the ATP, then you can't pay for the sodium potassium pump. You can't pay for all of the processes that Dr. Doig talked about earlier in the semester when she talked about the damage that can happen from hypoxemia. And then the other problem, that's the oxygen problem. And then the other problem is a buildup of the carbon dioxide. We have too much carbon dioxide in the blood. And I'll explain in a moment, this results in a change in the acidity of the blood. The blood becomes more acidic as we build up carbon dioxide. And it's not immediately obvious why that happens, but I'll show you. Let me make sure that we are all on the same page. We are manifestations of pulmonary disease. We are about halfway down on page 2. All right, so going into hypoxemia in a little more detail. As we've said, any of those three factors can be affected. We can have decreased alveolar ventilation. For example, somebody could be slowing down their breathing. Maybe they've OD'd on narcotics, or they're choking, or some other limitation in the airflow in and out. There can be decreased gas exchange. This can happen, say, with an increase in edema in the lungs. Or we can have decreased alveolar perfusion, a limitation in the blood supply here. And this could happen due to a blood clot. How are we going to assess hypoxemia? There are a couple of ways. Fortunately, there is this technique called pulse oximetry. We've probably all experienced it, having this little machine put on the end of our fingers. It's a non-invasive measure of oxygen saturation. It's based on the fact that hemoglobin actually changes color. The more oxygenated it gets, the brighter red it is. And I kid you not, there's a little light here that gets shined on one side of the finger, and then on the other side, there's a sensor, and it's detecting the color of the light that's coming through. So what wavelength exactly is that light? So how red is the hemoglobin? And that gives us an estimate of how oxygenated our hemoglobin is. In other words, what percentage of the hemoglobin has oxygen attached to it. Normally that number is somewhere between 95 and 99, in the high 90s, that's normal. But people can drop lower than that. And if they drop lower, it's an indication that we've got a problem with one of those three factors, either ventilation, perfusion, or gas exchange. Let's see, what does it stand for? S is for saturation of oxygen, P for pulse oximetry, and O2, of course, is oxygen. And so we expect a low SpO2 for somebody who's having a difficulty with the pulmonary system. If they drop, let's see how much I want to go into here. If they're dropping into the 80s, there's getting to be a serious problem. If they're into the 70s, they need some supplemental oxygen. Now, if we're very concerned and we need a better estimate of their oxygen level, there is a more invasive test that can be done. This is done with an arterial blood sample. So the blood's being taken not from the typical kind of vein that we do any other normal or typical blood tests. We need arterial blood, so blood that had just come back from the lungs, went to the heart, got pumped again out of the left side. It hasn't dropped off its oxygen to the tissues yet. That's what we want to know. What is the oxygen in that blood? And so arterial blood gas is the test. ABG is how it's abbreviated. And we expect a low PaO2. The P stands for the partial pressure of oxygen, A for arterial blood. This is done by a specially trained phlebotomist. If you need a one-time sample, the phlebotomist can just go in directly to the radial artery and take a sample. If it's somebody who's critically ill and sampling is going to have to happen repeatedly, the specially trained technician can place a line that stays more permanently, and ICU nurses can draw samples from that line. There's a much bigger risk of bleeding when you go into somebody's artery, and it's much more painful for the patient. So this is not something that we do lightly. The other signs of hypoxemia that we can assess as nurses. Remember that I said the hemoglobin gets brighter red the more oxygenated it is. Well, it doesn't turn blue exactly, but it's a duskier shade of red. And so through the skin, that looks kind of bluish or kind of grayish. And so if we see in the periphery, if you can see it in the fingers, this could be caused by poor circulation going out to the hands and the feet. And you always want to look at an area where the patient's melanin is not going to get in the way of your ability to see this. So look at nail beds rather than just depending on the color of the skin. If the person is having a severe problem with ventilation problem or a perfusion problem in the lungs, and have severe hypoxemia, we'll see central cyanosis. You can see in this patient, the lips look kind of bluish, and even the tip of the nose is looking a little duskier, a little bit gray. But let's rely as much as we can on areas that are not going to be covered up by the melanin that some of us have in our skin. So take a look in the mucous membranes. Okay. So we said that there were two problems that could result. So you have not enough oxygen, or the other problem is having too much carbon dioxide. And actually both of those things often happen at the same time. That other problem, the complementary problem, having too much carbon dioxide, that's known as hypercapnia. And it's caused by exactly the same things that cause the hypoxemia: decreased ventilation, decreased gas exchange, and or decreased alveolar perfusion. And since it has the same causes as hypoxemia, it's usually seen with hypoxemia. Now, here's the problem. With the hypoxemia, we could assess it with that non-invasive test. You just put the thing on the finger and look for oxygen levels. There is no comparable test like that for carbon dioxide levels. So if you are an inventor or know some inventors, do put a bug in their ear about this. We could definitely use a non-invasive way to assess carbon dioxide levels. At this time, we do not have one. We are stuck with just doing the really invasive, going into an artery and getting an arterial blood gas. In this case, we're looking for PaCO2, the partial pressure of carbon dioxide in the arterial blood. And it's the same thing going into an usually the radial artery. Okay, and this we can go over finally. Why is carbon dioxide such a problem? The problem is that it leads to a change in the pH. And that change in the pH is putting it on the acidic side. And since the problem is related to the respiratory system, we call this respiratory acidosis. As we've said, we get the carbon dioxide from the metabolism. That is the breakdown of our food molecules, carbs, proteins, lipids. We need those, we metabolize those for energy. This is normal. It's also normal to have water in the blood. These two molecules react with each other. A small number of them will react with each other and form something known as carbonic acid. If you need to do this quickly, let's take a look. Hydrogens, there's 2 here. That's the 2 hydrogens there. Carbon, there's the 1 coming from the carbon dioxide that's there. And then oxygen, we've got 2 coming from carbon dioxide and 1 coming from the water. And so that's where this comes from, H2CO3. That is the formula for carbonic acid. And we need carbonic acid in our blood. That's not bad that we have carbonic acid. We absolutely rely on carbonic acid to help us maintain that 7.35 to 7.45 average pH of the blood. That's what our body is most comfortable at. However, if we have too much carbon dioxide, I didn't mention here, the reaction can be reversible depending on what the body needs. But the more carbon dioxide that's in our blood, the more the arrow going this way towards making carbonic acid, the more molecules are going in that direction. So we have a buildup of carbonic acid, and we end up getting more and more acidic. Before we get to that, let me just mention, more and more acidic means lower pH. I'm not going to go over the details of why that is that way, but you probably remember that from chemistry. I'm going to give you a way to remember it, because this is a place where people lose points on exams because they get these backwards. If you know the expression drop acid, yeah, when things get more acidic, the pH drops. So drop acid. So increased acid, lower pH. Let us get to abnormal breathing patterns. We are now at the top of page 5 in the lecture notes. So we can alter the rate, depth, regularity, and effort of breathing. We can either breathe too little, or we can breathe too much, breathe too fast. So hypoventilation, I've underlined the O to point that out. Inadequate alveolar ventilation. If the patient's breathing too slowly, the prefix that means too slowly is Brady. Pnea, P-N-E-A, refers to breathing. So bradypnea is breathing too slowly at a decreased rate. It can also be they're breathing at the normal rate, they're just not breathing very deeply. And there's no separate term for that, they're just breathing shallowly. The opposite problem, hyperventilation, there's too much breathing. The lungs are removing carbon dioxide faster than it's being produced. This is known as tachypnea. Tachy is fast, and again, the pnea for the breathing. This is an increased respiratory rate. So typical is about 16, 18 times a minute. Somebody who's tachypnic is breathing more than 20 times a minute. And where we typically see that is when somebody's having a panic attack, usually that's self-limiting, the hyperventilation. You usually don't have to do anything about it. It's the hypoventilation that we have to intervene typically and provide some oxygen to the patient. And there's some more terminology about breathing that I need to introduce here in the overview video. This term dyspnea, dys of course means not right, and breathing. This is a subjective measure. Typically it's the patient that has to tell us that they are short of breath. It's often described as short of breath, and it's abbreviated in notes as SOB in the chart. They may say they're breathless. They get short of breath. If you're working with a patient who's nonverbal, for example, an infant, and you might have to tap into other more nuanced things like flaring nostrils or use of accessory muscles, the patient will start using the sternocleidomastoid muscles to kind of lift up the rib cage and help themselves with the breathing. So that's dyspnea, shortness of breath. Then there are some specific types of dyspnea. So the patient at rest may be fine, but they may describe shortness of breath when they walk somewhere or when they go up a flight of stairs. This is dyspnea on exertion, or DOE, is sometimes abbreviated in the chart. Another one that it's shortness of breath, but again, not all the time. It's dyspnea when lying flat. This is referred to as orthopnea. So difficulty breathing depending on position. And why it happens is this: when the patient is standing or sitting, if there's fluid in the lungs, it accumulates down at the bottom. And so although it is interfering with breathing, it is interfering with the alveoli, the ventilation in the alveoli, it's only affecting this field right here. Whereas when the patient is lying down, water accumulates in the lowest part of something. And so there's more alveoli, throughout this area of the lungs. And so this accumulates here, and especially bad for them if they're lying on their backs. This is where you have the most alveoli, because the lungs are kind of pyramid shaped. They're pointy towards the front. Oops. And flatter in the back with lots of alveoli here. This is one of the reasons you probably heard about this with COVID patients. They're put in the prone position on their stomachs. And that's so that the fluid will accumulate here and allow more of these alveoli to be open and available for gas exchange. All right, so that's orthopnea. And so the patient may not tell you that they're feeling orthopnic. But if you see this, if you see a patient who is trying to elevate their hands, kind of open up the rib cage, or they're punched forward on the tray table, and trying to put their weight forward, it's again pulling the fluid towards the front, and making it a little bit easier for them to breathe. And paroxysmal nocturnal dyspnea. This is an attack of severe shortness of breath and coughing. It wakes the person up at night, and it's a little tricky to understand. We'll get to talking about how there are some cases where the patients end up with edema in their legs. They have a lot of fluid buildup in their legs, and then at night when they lie down to go to sleep, they elevate the legs. It's easier for that fluid to get back into circulation. Now you have a lot of fluid that was in the legs during the day, and now it's finding its way throughout the body, including into the lungs. And so that's why they suddenly wake up with this feeling like they can't get enough air. And then the final topic is hemoptysis. Hemo referring to blood, and the PTYSIS, coughing up something. So this is blood coming up in the sputum. You know that there's a great blood supply to the lungs, but that blood is supposed to stay in the capillaries surrounding all those alveoli. When there is an infection and we have inflammation, some of those tissues kind of break. There's damage to the tissues, and some of that blood escapes out of those capillaries and gets into the alveoli, and then ultimately back into the bronchi, and then ultimately out through the trachea, and the patients can cough up blood or bloody secretions. And again, that is known as hemoptysis. And that covers the things that I need to cover with you right now. In class, we'll do some questions first, reviewing that information that we just went over. And then I'm going to give you some bonus pulmonary anatomy. I'm not going to introduce it here because I want you to hear it right before we start talking about the problems that arise that are related to this, a little bit more information about pulmonary anatomy. So see you in class.